the use of blood pumps, which is most common in the United States and across the world to support open heart surgery, involves essentially all the time the use of continuous flow pumps, and they're effective, but we know that there are downside risks or downside accompaniments to the use of these pumps while we're doing open heart surgery, and so in effect we create an injury to allow us to treat a condition, and we hope that the injury is going to be short-lived and not associated with long-term disability, but we don't know that it will be, and sometimes it probably is. I think the current state of the art, as good as it is bad enough to justify looking for alternatives or iterative evolutionary, revolutionary improvements. Acute kidney injury is ubiquitous in a post-operative intensive care unit for children, particularly in newborn babies and very young infants. It is manifest in a variety of ways. In its simplest and mildest form, we see a slight elevation of certain chemicals that are normally found in low levels in healthy people, but those levels rise if the kidneys aren't clearing them normally, and that's our sort of our first indicator that the kidney has been injured. But what we also see, in not uncommonly, is that the amount of urine that's generated by the kidney or the injured kidney is less than normal, and so babies tend to retain fluid and become swollen as a result of the kidney injury. Now, for most children, the kidney injury is not permanent, or at least it's not so severe as to cause the need for dialysis, for example, or in extreme cases, kidney transplantation. But it certainly contributes to the length of time a child would be what we call fluid overloaded or swollen, which in turn may translate to a longer time on the ventilator as recovery from surgery is underway. It alters the metabolism of certain medications that we might administer to help somebody recover from an operation or to treat an infection if they had one of those. So it complicates their recovery, complicates their management. And it's interesting from the perspective of a practitioner in this arena that we assume that the acute kidney injury, which is not present before surgery and is present after surgery, must have been caused by the surgery or something related to it. But our operations are working on the heart. So how do we injure the kidney? By working on the heart. We don't touch the kidney, we're nowhere near the kidney, so what we must do is change the way the kidney gets its blood flow. There must be something about the flow which is adequate in amount and adequate in pressure, but still is inadequate in some other way, and that's one of the reasons that this concept of a pulsatile pump, which almost exactly mimics what the heart normally provides when the kidney is uninjured, that's one of the reasons that there's a real interest in this. We are pretty confident, particularly in small children, that the use of one of these types of pumps, the continuous flow pumps, is probably related to this capillary leak microcirculation problem, and the preliminary results with the VentriFlo pump suggest that that's less likely to happen independent of whether or not the kidneys are injured. And it may very well be that, for example, in adults where the kidneys may be less susceptible to injury, that the capillary leak phenomenon may be more important. But that microcirculation aspect of the VentriFlo pump, which I think is likely to be a significant mechanism of its benefit, is very important. On average, our operations tend to be longer. The complexity of what we now do in the operating room is an order of magnitude more than it was a generation ago, and it takes longer to do these more complicated operations. And in general, the people who require the longest operations are the smallest, most vulnerable children. The consequences of cardiopulmonary bypass or prolonged extracorporeal circulation, where there's an oxygenator involved, ECMO, are much more visible, literally visible, in the pediatric population. If you take a 75-year-old patient to the operating room and replace his aortic valve or do a coronary bypass operation and come by and see him in the afternoon, he will likely look very much like he did before surgery, except that he'll have a scar and some bandages and a few drainage tubes. If you take his grandson, who's a week old, and do a Norwood operation on him and come by and see him, he may have gained 20% of his body weight and retained fluid in that period of the operation. His lungs will be dramatically different than they were in the morning. So I think that in terms of bang for buck benefit, I think that children will probably demonstrate a larger benefit than adults, and I think that the safety in children is something that people have worried about, but there's a risk-reward here that's quite high. I mean, in both circumstances, whether you're talking about a tiny baby or an elderly grandmother getting an operation, we use the same kinds of technology. And benefits that are seen and maybe more immediately apparent in children can certainly be extrapolated to adults, and then it becomes how big is the difference. If you can shorten somebody's length of stay by 12 hours, that might not sound like much, but over a larger population, it is much. So what I would say is that here with children, you have potentially a substantial effect on a relatively smaller population. So you get proof of concept in children where the magnitude of the benefit is larger on an individual patient basis. But even if the magnitude is smaller on an adult population, if you talk about a population, the total amount of dollars spent or the total savings for the healthcare system, the total expenditures on coronary bypass surgery, for example, will add up into many millions or more of dollars. A pump that could get somebody out of the hospital a couple of days earlier, out of the operating room quicker, get back on their feet or back to their mother or back to whatever quicker. It's very hard to know what people will pay for things, but especially if you're talking about the life and the health of a child, people will pay a lot of money for changes that may not sound significant initially. You're in the hospital one day less, who cares? Well, if the hospital's a dangerous place to be and your kidneys are better as well, then pretty much everybody will care. And people will pay large amounts of money for changes like the magnitude of those that we would project would be available if VentriFlo can do what it seems like it can. If VentriFlo can do what it seems like VentriFlo can do, if it can deliver on the benefits that have been promised by the preliminary work that's been done so far, I absolutely think that it can change the standard of care. And standards of care can change literally overnight. This is a much more towards the revolutionary end of a change than an evolutionary end of a change, because it also, in my world, which affects children, could have a big impact on children quickly that we'd know about. I'm very eager to get access to the technology. You will know very quickly whether or not this is going to be as good as it sounds like it is. And if it is as good as it sounds like it is, you won't be a restaurant on the corner competing with a bunch of other restaurants. Everybody's going to leave McDonald's and come to your restaurant. They will not go to McDonald's again, even if there's a price point difference. We're talking about with VentriFlo is almost a snap-in. You take this out, you pop that in, now you've got a pump that's way better than the pump you had before. So I think that the speed with which this change could happen is incredible, would be incredible. We're talking about a period of certainly less than 5 years. It would be enormous. I think that we spend a great deal of mental effort, mental time, mental capital imagining ways that we could reduce things by 1 or 2 or 3%. So if we're talking about a reduction in convalescent time, or a reduction in a surgical error committed because of someone being in a hurry, or a reduction in the need for medications of a certain amount by 5 or 7%, that's absolutely enormous. It would, that's the kind of thing that careers are made on, Nobel Prizes are won for, companies become publicly traded for, et cetera. So these kinds of changes could be absolutely massive. It remains to be seen. Regardless of what things look like 30 or 40 years down the line, in an immediate sense, if you have a child who may be less swollen after surgery, whose time on the ventilator may be shortened by a day or 2 days, or whose return to receiving nutrition orally as opposed to intravenously is sped up by a day, if you could reduce the length of time in the hospital, or the length of time on the ventilator, or the length of time in the intensive care unit by 1 or 2 days, if you multiply that across a population of tens of thousands of children getting heart surgery a year, that starts to turn into real money. And what we're talking about here, if we could reduce acute kidney injury, reduce fluid retention, swelling, lung injury from excessive fluid, if we could reduce that significantly, enough so that we could shorten the stay, I think that we would see dramatic cost savings. Let's say that there's 200,000 people a year in the United States who have open heart surgery, and 200,000 people have an average length of time in the hospital, let's say, of 7 days. You can do the math for that, and if you could reduce that by 5%, that's 5% reduction in hospital days, 5% reduction in exposure to risk, lives saved, complications averted, etc. That wouldn't just revolutionize heart surgery, it'd revolutionize health care. And you know, those are the kinds of things that, obviously saving lives and saving misery and saving pain and saving suffering is great. Also saves money. So you're saving suffering and saving money at the same time. That's pretty revolutionary.